So thank you everyone for coming to the Choosing Wisely June webinar. My name is Anne-Marie and I'm the Health Services Lead for Choosing Wisely. So firstly, I would like to begin today's webinar by acknowledging the traditional owners of the lands that we're on today. So I'm in Melbourne and over here we have the Wurundjeri people of the Kulin Nation. I would like to acknowledge elders past, present and emerging as well, but also on all the respective lands that you are dialing in from today as well. So thanks for coming, and it's my pleasure to introduce Riley Hazard, who works at Western Health in the ICU department, and he will be presenting on his project on coagulation testing. So I'll hand over to you, Riley. At the end of the presentation, you can stop sharing your slide, and if the audience can just put in any questions in the Q&A section, then I'll read it out to you as well.
Okay, thanks, Anne-Marie. All right. So thanks for the introduction, Anne-Marie. I'm going to talk today about routine coagulation testing in the ICU and how often these tests become abnormal. So I'm talking about two things. First, about a retrospective study that we did at Western Health in Melbourne. And then secondly, about a planned prospective study based on the results of our original study. So first off, I don't have any financial disclosures, and I would just like to acknowledge all the collaborators on this project: Forbes McGain, Madeline Cork, Dominic Grant, and Craig French. So a bit of background, and I'm sure most of this is quite familiar to those who work with Choosing Wisely. But we know that diagnostic testing that offers little patient value has become increasingly common. Now, there are a number of reasons for this, and I've just highlighted a few of them here. So there's defensive medicine. This is essentially ordering tests to protect yourself from medical legal concern. There's also junior staff. So there's been observations that junior staff often order more tests to protect themselves from criticism from their superiors. And also order sets. So order sets are essentially a collection of tests, commonly pathology tests, that are ordered based on a certain patient presentation or in a certain setting. Now, order sets aren't necessarily bad, but they do lead to a great deal of tests that aren't necessary. So all of this unnecessary diagnostic testing contributes to a number of negative externalities. There's the financial burden. It's estimated in the United States that around 20% of all healthcare spending is due to unnecessary diagnostic tests. There's also patient harm. So there's the discomfort and pain from a needle stick. There's also the potential resulting anemia. And then there's the risk of a false positive that might necessitate further invasive testing. Additionally, patients that are presented with a false positive test result have the mental burden of dealing with that result and having to represent for further testing. I'd be remiss not to mention the environmental impact, as some of the previous webinars have discussed, and Forbes McGain, one of the collaborators on this project, has done quite a lot of research. So we decided to focus specifically on diagnostic testing in the intensive care unit, where there's generally quite a lot of testing to monitor critically unwell patients. So at Western Health, there is a policy of routine testing for full blood exam, urea, electrolytes, creatinine, liver function tests, and coagulation tests. There's actually not a national standard for how often ICUs should do this testing, but this is what's done at Western Health. So we decided to focus specifically on coagulation tests because these tests are collected in a separate blue tube, and they don't give as much information as some of the other tests. The most important reason we focused on this, though, is if a clotting test is abnormal, usually there isn't any treatment that is given unless a patient is obviously bleeding, in which case coagulation tests, clotting products might be given. This is quite different from some of the other tests, such as if you have abnormal electrolytes, you might replace those. If you have a low hemoglobin, you might give a blood transfusion. So clotting tests can become abnormal for a number of different reasons. In the ICU, it's commonly because patients might be bleeding, they might have an infection, they might have liver failure, or they might be on some sort of anticoagulant. So we had this question: if we are testing every patient every day with coagulation tests, and they are admitted to the ICU with a normal test, how often do they become abnormal during their ICU stay? So we conducted a retrospective analysis at Western Health. We did this between January and June 2017 and analyzed the data in 2019 and 2020. So Western Health has two ICUs at Footscray and Sunshine. And we used a convenient sample of 500 patients that were admitted with a normal coagulation profile. We define that as an APTT less than 40 seconds and an INR less than 1.5 on ICU admission. Importantly, we excluded patients who were on therapeutic anticoagulants such as low molecular weight heparin or warfarin, because there would be a clinical indication to monitor the clotting profiles of these patients. We looked at a couple of subgroups as well. So we defined some patients that are being high risk of developing a clotting abnormality. And those were the patients with sepsis, chronic liver disease, bleeding, or some sort of known coagulation disorder. So these are some of our results. Just to orient you here, in the first column there, we have all of the patients in the cohort. The second column are the patients whose coagulation became abnormal, and the third column is the patients whose coagulation remained normal. So we had 469 total patients because we excluded 31 patients who are on therapeutic anticoagulants. The main finding here is that we found that only 61 patients total, so 13%, actually became abnormal when they were admitted with a normal coagulation profile. We also see in the middle of the table there at the ICU length of stay, a slightly longer length of stay for the patients whose coagulation became abnormal. We might expect this because these patients might be more unwell and more likely to develop an abnormality in their clotting profile. There were no difference in the categories of diagnoses between these two groups. Mortality was also the same. There was no statistically significant difference between the two. The Apache 3 score was higher for the patients whose coagulation became abnormal. Apache 3 is a numeric score for ICU disease severity. So this sort of makes sense. Patients who are more unwell might be more likely to develop a clotting abnormality. This is just a continuation of this same table. So at the top there, we see our two subgroups. So it's our high risk of bleeding and our low risk of bleeding groups. So most patients, 71%, were defined as having a low risk of bleeding. And we do see the patients who a priori had a higher risk of bleeding did, in fact, were more likely to become abnormal. In the middle of the table there, if you see the received clotting products or received vitamin K, it's sort of like what I was saying before, where most patients who do develop a clotting abnormality actually don't have any treatment. So overall, only 6 patients received clotting products, and that was 4 of the total 61 patients who had a coagulation becoming abnormal. We also see towards the bottom that more patients had multiple clotting tests per day if their coagulation became abnormal. And this sort of makes sense because it suggests there might be clinical concern about the coagulation profile of these patients. And then finally, at the bottom, we're looking at the distribution of clotting tests for patients. So most patients who became abnormal were just above our threshold of 1.5 for INR and 40 seconds for APTT. And you might notice there that those two numbers don't add to the total number of patients whose coagulation became abnormal. That's just because some patients met both criteria. So we're looking here at a survival curve. On the y-axis, we have the fraction of patients who's with a normal coagulation profile. And on the x-axis, we have time in hours. So at 0 hours, all patients have a normal coagulation profile because that was our inclusion criteria. The main finding here is that we see over the first 36 to 48 hours, we see a sharper decrease in this curve, suggesting that most of the patients have their clotting profile becoming abnormal at that time point. At the bottom is a table corresponding to this survival curve, and you can see there's that total of 61 patients. And at 48 hours, we have 57 of those patients have already become abnormal. So this is a survival curve in a similar fashion, but we're looking at these two subgroups, the low risk and the high risk groups. The high risk group were those with the chronic liver disease, sepsis, or some sort of known coagulation disorder. Main finding here is that we see the high risk group are more likely to become abnormal at an earlier time point than the low risk group. There's a hazard ratio of 3.9, suggesting these high risk patients are 3.9 times more likely to become abnormal at an earlier time point. And again, we see that same pattern of this sharp decrease in the curve over the first 48 hours. And just on the right side of the screen here, we see overall that the low risk patients, their median time to become abnormal is just under 1 day. And the high risk patients, the median time to become abnormal is just over half a day. And this is just looking at the data in a slightly different way. So essentially have a rectangular pie graph here. So 87% of patients, their coagulation profile remained normal the whole time. Had 13% became abnormal. And overall, less than 1% of all patients became abnormal after 48 hours, just to emphasize how unlikely it is to become abnormal after 48 hours. So our conclusions from our retrospective study. Most patients in the ICU with a normal coagulation profile on admission, we think that further routine testing is of little clinical value. In the subset of high-risk patients, additional routine testing beyond 48 hours is of limited clinical value. Now, if we extrapolate our results based on the ICU length of stay, we could say that if we restricted testing to 3 days maximum, we would see a 25% reduction in overall clotting testing. If we restricted testing to 2 days maximum, a 35% reduction, and 1 day's maximum would be a 55% reduction in clotting tests ordered. So based on the results of this study, we asked, can we safely reduce the frequency of routine coagulation testing in the ICU at Western Health? So there are a few ways to approach this, and some of the previous webinars have already discussed this. There's educational approaches, there's guidelines, hospital guidelines that can be written. There's regular audits and feedback that can be done. There's also clinical decision support. So this can be things built into the electronic medical record system, can be paper-based forms. And I think the best approach to changing testing is really going to be multi-pronged, and it's going to be using all these different approaches. We decided to focus for this prospective study specifically on a clinical decision support tool. So we did this by building an alert into the electronic medical record system at Western Health that pops up when a pathology test is ordered based on certain criteria. Now, the reason we decided to use a clinical decision support tool is we feel it's most likely to have a sustained effect. In the ICU, much of the pathology test ordering is by junior staff who have quite a high turnover. Many of them will rotate onto different rotations or go to different hospitals. And so we felt it was most likely to have a sustained effect rather than educational approaches, which can be very effective, but do require continuous training. So just give an example of how this alert will work. So let's say you have a patient who comes to the ICU and they have an INR of 1.1 and an APTT of 29, so it's normal. 24 hours later, you order clotting tests again, and again, it's normal. The patient's now been in the hospital, in the ICU for 24 hours. 24 hours later, clotting tests are ordered again. Again, it's normal, and the patient has now been in the ICU for 48 hours. So at this point, we say it's extremely unlikely for a patient's clotting profile to become abnormal at this point. So if you order clotting tests again, we've designed this pop-up, and this is just a mock pop-up at the moment. This patient has had normal clotting tests for the last 48 hours. Less than 1% of clotting tests become abnormal after 48 hours. Do you need this clotting test? And then please disregard this message if the patient is on therapeutic anticoagulants. And the ordering doctor will have the option to either continue the order or cancel the order. Now, if they continue the order, we'll have a second pop-up. And this is just for research purposes here. please explain why you would like to order clotting tests, even though the last 48 hours of clotting tests have been normal. And they can choose consultant order, patient deterioration, or some other reason. So we'll be looking at a few different outcomes. Our primary outcome is the mean clotting test ordered per 100 patient days before and after we start this alert. The other outcomes are the number of times the alert fires or would have fired before the alert was initiated. We'll also be curious about how often the alert was overridden, the reasoning for overriding the alert, and also staff's opinion of the alert. So this is just a general overview of how we plan to analyze the data. On the y-axis here, we have the mean clotting tests per 100 patient days. And on the x-axis, we have time in months. So we plan to run this alert for 6 months. And we'll also look at the 6 months prior to compare the rate of clotting tests. So the lines here, the blue line represents the rate of clotting tests ordered over time. And we want to see a substantial decrease in this rate, the beta 3 value, when the alert is initiated. The reason we want to analyze the data like this is there could already be a downward trend in pathology tests being ordered. And we want to say for sure that the alert caused a large decrease. So some things we're thinking about for this study. One is the risk of alarm fatigue. I'm sure anyone here who's worked with an electronic medical record system is used to things popping up on the screen. And once you've seen it enough, you get pretty quick to ignore. So that's something we're continually speaking with staff about to make sure they're not getting too annoyed with it. There's also some limitations. So this is an unrandomized study. It wouldn't be practical to randomize some doctors or some computers to have certain rules built in. So we have to deal with a real world scenario here. So there certainly could be other things that contribute to changes in behavior of ordering pathology tests. There's also the Hawthorne effect. So some of the staff will be aware that we're monitoring their ordering practices. They might change their behavior for that reason alone, and there really isn't too much we can do about that. That's the end of my presentation. I'm happy to take questions at this point. And I've also just included my email in case anyone has any questions at a later time point. Thank you.
Thanks, Riley. It was a really great presentation, and thanks for explaining the graphs so well. So I'll just open the floor to questions from the audience, and you can put it in the Q&A box or the chat box, and I'll just have a look at both of them. So feel free to ask questions. Just while we're waiting for that, I might ask a couple of my own questions, Riley. So how did you go about setting up an alert in the EMR? And I guess, what did you factor in and what did you find was most effective when setting it up?
Yeah, so we spoke with the EMR team at Western Health, but also I think known as the digital health team. And they were pretty excited to work with us on this. I would say, though, that there is quite a lot of bureaucracy in setting these up. There's lots of hoops to jump through. And that's part of the reason we set a very conservative estimate of 48 hours is the threshold. So I think once we get this set up, hopefully it won't be any more work. But it is a bit of setup. And I think things are changing at the time too, as hospitals are sort of updating their EMR systems, and it might become easier in the future.
Thank you. We have a couple of questions from Chris Long, who's at Austin Health. So the coags, did you get Cerner to create the pop-up? And he also said, great initiative.
Yeah, thanks, Chris. So the Cerner team alone isn't doing the pop-up. We have our EMR team at Western Health who's been helping with this. And like I said, they've been quite happy to do it. I guess we just have some further requests from them because we're doing this for research purposes. So we want to be able to extract a certain amount of data. Making the alert alone for them is quite easy. Ours is a little more complicated just with the follow-up question as well.
And Chris has another question. Out of interest, how is your Choosing Wisely team resourced in terms of EFT? If you don't mind him asking. I'm not sure if you're able to answer this.
Yeah, sorry. Unfortunately, I'm not able to answer that question, Chris.
Yeah, Chris, I might follow up. So Sophie Gore is leading the initiative at Western Health. So I can follow up with Sophie and I'll get back to you because I have your email as well. Any other questions? So just looking at sustainability with your project as well, Riley, have you seen any changes in the routine coag testing, I guess, behaviour after the study was conducted?
So I don't have any hard data to support that, but I've been told anecdotally from some of the intensivists that they have, after publishing this study, that they have seen a bit of a change in behavior, and that after a couple of days, people are questioning if it's really necessary.
That's great. And do you know if they have any plans with sustainability long term, if they're going to go ahead and, I guess, adopt these changes?
Yeah, so I mean, I think this alert will hopefully create some sustainability, but I really think we do need some of those other approaches as well.
Yeah.
Continual education sessions. Like I mentioned, that it is a challenge with the junior staff because they are constantly rotating. But even a once a rotation sort of quick session about the importance of having targeted testing would be quite an effective thing to do as well.
Yeah, and I wonder if something like online modules could be a good way of ensuring that you don't have to have someone there face to face going through the same thing as well.
Yeah, absolutely. I would save a lot of time and resources. For sure. Yeah.
Great. And have you looked at the practice of other routine pathology tests in the ICU?
Yeah, there has been some look at that. As I mentioned, we focused just on coagulation tests because it's a bit of an easy target. It's its own pathology tube, and often we don't do much depending on the result. Forbes has been looking at liver function tests recently because it's a bit of a similar story where if the values are abnormal, unless the clinical picture fits some sort of pathology, usually you don't do much. One difference, I guess, is that it is in the same tube as UVCs, but it does still add costs and burdens resources. Absolutely.
Right, that would be good to hear more about that as well. I think you've just got a couple of nice comments there saying congratulations. And Chris, I'll get back to you. I'll reach out to the other health services and get you some information on, I guess, what support is happening with Choosing Wisely at different health services. Riley, did you have anything else to add?
No, thanks so much. Thanks for having me. Happy to share some of the progress we've made at Western Health.
Yeah, it's fantastic, and it's a really good project to showcase as well. So thank you for sharing. I'll wrap it up there. So thanks everyone for coming, and I'll see you next month.